So before I introduce Anne, again, I think that the reason why we wanted to highlight this issue in this panel is that if we look at global issues, a lot of times the challenge really comes down to that we have needs which are really legitimate on their own, and they're different needs. And sometimes we get it confused. Are we talking about the same thing, or are we talking about different things? And so I think that this forum and all countries have really focused, for example, on the need to know. Surveillance is critical. We need to know what's out there just to be ready, to look ahead. We need that information both to develop the technologies that we are going to have to deal with the issues. On the other hand, a world which does not have equity, which does not have fairness, flies completely in the face of the values that we hold. And so we had two issues which were equally weighted, and they were not really in juxtaposition with each other, but they had to be accommodated. And in this situation, it took 4 years. You know, I think I didn't realize it was 8 words per day. That's a little bit, yeah, that's a little bit amazing. But you need that time to digest the issues. You need that time to let all of those parties which are not sitting in the room, but which represent countries and which make the decisions, to let those issues seep through. And I particularly wanted the 2 ambassadors to be here because they were critical in coming up with one of the breakthrough issues. I remember when they stood up and they said, benefit sharing and virus sharing are on equal footing. And this summed up where we needed to go. And it was one of the great moments, I think, in modern public health. And so they are very instrumental to this. So let me now introduce Anne Huvos, because Anne probably knows more about the PIP than any other person alive. I think she knows every single one of those 8 words per day words, and she has lived and breathed them. Anne is joined WHO in 2006, really to begin working on this process, and so she is head of the group which manages the PIP framework. And I think that in addition to going through all of the negotiations which she has, she's also the person who most knows the challenges which are coming up in the future facing the framework. And so, Anne, if I can turn to you.
Sure. Thank you, KG. And really, it's a huge honor to be here. I've been asked to address 3 questions. The first, what does the PIP present in terms of an international framework? Second, what challenges does it face? And third, what are some options for going forward? And I'm supposed to do this in 7 minutes. So I won't talk too fast, but I probably will use some acronyms. And they are up on the board if you need to refer to them. So first, what does the framework represent? I guess the most important answer is that PIP is the result of a 4-year investment by WHO member states to resolve 2 critical issues for public health security. Make sure countries continued to share influenza viruses with pandemic potential, or IVPPs, for risk assessment and development of pandemic vaccines. And then second, to ensure greater equitable access to future pandemic vaccines by all countries based on public health need. This was irrespective of development status or other financial considerations. So as we've heard, the roots of PIP go back to the reemergence of bird flu in 2003 and fears that we were at the beginning of a devastating pandemic. But as was mentioned by the 2 ambassadors, the spark that really triggered these complex negotiations was developing countries losing trust in the global system for virus sharing and access to vaccines. In essence, developing countries felt that the WHO coordinated system of virus sharing was not a fair deal for them and did not provide reasonable protection for their people. This was a significant thing. So the PIP process was the start of rebuilding that trust, which facilitated the resumption of virus sharing. Just as importantly, however, and up to now, PIP also represents a successful approach to partnership with the private sector. So in the 7 years since the framework was adopted, we've resumed virus sharing. We've collected over $163 million in what's called partnership contributions, and those funds have been used to strengthen global pandemic preparedness capacities where they're weak, and to slowly build a response fund that can be used at the time of the next pandemic. We've also signed many contracts that secure approximately 10% of future pandemic vaccine production for WHO, and that WHO will be able to send to countries in need at the time of the next pandemic. So right now, this represents about 400 million doses of vaccines, and if time's on our side and manufacturing technologies continue to improve, this figure will increase. But PIP doesn't operate in a vacuum, and so this brings up the second question: what challenges does PIP face? So since 2011, we've seen two important developments in the global context. The first is the increasing use of genetic sequence data, or GSD, and the second is the entry into force of the Nagoya Protocol. Both of these developments are raising challenges for PIP in different ways. The increasing use of GSD potentially puts at risk WHO's access to vaccines and other critical pandemic response products because of the nature of those contracts that I mentioned that we're signing. Those contracts must be signed by any entity that receives physical PIP biological materials from GISRIS, the system that Wenqing mentioned. If a product, for instance a vaccine, is manufactured only with GSD, then WHO cannot require the manufacturer to sign a contract to share its product with WHO. So while this is all hypothetical right now for vaccines due to regulatory processes, one of the main objectives of the framework could be frustrated in time if those processes change. So the first challenge is what to do about GSD and benefit sharing under the framework. Turning to the second development, the entry into force of the Nagoya Protocol that Steve mentioned, this raises different issues. So what's Nagoya? It's an ABS, or Access and Benefit Sharing Treaty. Its basic premise is that anyone that wishes to access genetic resources, or GRs, if they want to access those of a country, they must work with the country to agree on what benefits will be provided back to that country in return for use of the GRs. So this is essentially a bilateral system. The treaty has nearly 110 parties as of now, and all of them are in some stage of development of their national implementation law, and these can and do differ substantially from country to country. Now, Nagoya recognizes that some GRs are already covered by other access and benefit sharing instruments, and in those cases, it basically says that's fine if those instruments are consistent with Nagoya. So, for instance, for IVPPs, if the PIP framework is considered to be an access and benefit sharing instrument that's consistent with Nagoya, then Nagoya will not apply to IVPPs. Now, this is a problem for seasonal influenza viruses because PIP does not cover seasonal influenza viruses. So Nagoya would apply to the sharing or access to seasonal viruses. This has the potential to disrupt the global system that relies on timely, rapid, broad sharing of viruses to develop effective seasonal influenza vaccines. So the challenge here could be summarized as how can we reconcile public health and Nagoya for the best public health outcomes? And that brings me to the last of the three questions, how to go forward. So Health Assembly 2017 requested WHO to develop analysis of the implications of these two factors on the PIP framework. So how would increasing GSD, use of GSD and implications of Nagoya affect implementation of PIP in the future? The analysis was done, and it sets out several options for each of these issues. And the solutions go from basically maintaining status quo, don't change anything right now, to flu-specific options, including adapting the GISRIS system, to the development of a broader instrument or several broader instruments that cover all pathogens. The next executive board and WHA will discuss the analysis and decide on the way forward. But 3 things are clear. The most important thing for WHO will be to act transparently, inclusively, and iteratively to maintain the trust of all its partners, public, private, non-governmental. We won't make the same mistakes as in the past. Second, there really are no easy answers, and any solutions will require compromise. And finally, we'll need robust communications to explain why this is also important for public health and how it affects countries and their populations. So with that, thank you, KG.
Thanks, Anne.